Good evening and welcome, everyone. Thank you so much for joining us this evening for our presentation of Before the Bump, which is brought to you by Jefferson Hospital as part of our wellness webinar series. We're so glad that you chose to join us this evening. My name is Bethany Perry. I'm an obstetrician gynecologist at Abington, and I will be serving as your moderator this evening. I will be presenting your questions to the panelists that joined me this evening. We have 5 of them, and they are very eager to share their knowledge and resources that will take you from bump to birth. Joining me tonight are Amelia Megges. She's a certified nurse midwife at Women's Healthcare Group. I also have Dr. Amelia Megges, who's at Abington OBGYN Associates, Dr. Carolyn Picone, who is at Women Care OBGYN, and Dr. Jimmy Ruiz at the Center for Gynecology and Women's Health. We are also joined by Jennifer Johnson, a certified nurse midwife at Abington Primary Women's Healthcare Group. For all of you who sent in questions tonight, thank you so much. You sent in so many questions, and you still have an opportunity to send in more. At the bottom of your screen, if you're on a laptop or a tablet, you'll see a Q&A feature. Please go ahead and enter your questions in there. If you are joining us by phone, not to worry, you can email your questions in directly to marketingevents@jefferson.edu, and we will pick them up there. We will do our best to get to as many questions as possible this evening. Of course, as per hospital and university privacy policy, we are unable to speak about specific cases or talk about the number of cases we've treated or current cases that we're treating now. Also, if you're currently experiencing any concerning medical symptoms, please contact your doctor. So sit back, relax. We have taken the liberty of muting your microphone so you can dig into those pretzels, no problem. So in just a second, I'm going to get to your questions, but before I do, I would love it if our panelists would introduce themselves so we can get to know them just a little bit better. So I think that, Yulia, we'll go ahead and start with you. How are you doing this evening?
Sure, great. Thank you for having me. I'm really excited to join the panelists and hear everybody's questions. I've been a certified nurse midwife for about 8 years, and I've worked in a variety of settings, including now at Jefferson. I'm really passionate about midwifery and serving the community, and I am originally from Northeast Philadelphia, so I'm really excited to be part of Jefferson and be serving the community I grew up in.
And we are certainly happy to have you back. And welcome, Dr. Amelia Megges. Oh, Dr. Megges, I think you have to unmute yourself, perhaps.
Thank you. Thank you.
Sure.
Hi, Amelia Megges here. I am one of the obstetrician gynecologists at Abington Hospital. I've been practicing at Abington ever since I finished residency in 2002. So I've been here for a long time, along with Dr. Perry and Dr. Picone and Dr. Ruiz. And been in the same practice, Abington OBGYN, for the last 15 years. And it's been a pleasure to deliver babies and now start delivering their children. And we have a wonderful department here, and we are thrilled to also have the complement of midwives now. So we're all getting along really well, and we're providing the best of both worlds, midwifery and obstetrics, here at Abington.
Wonderful. Thank you for those comments. And now, Carolyn Picone, Dr. Picone, you have the floor.
Hi, thank you, Bethany. I'm very happy to be here, and welcome to everybody who's logged on today. I've been an OBGYN at Abington Hospital for 25 years now, and I was born here longer ago than that. I really enjoy working here and working with all my colleagues here. So for all of you people who are watching, we certainly look forward to taking care of you in the future.
Thank you so much for that. And Dr. Ruiz, on to you. Welcome.
Thank you, Dr. Perry. Thank you to all our colleagues who have joined us for this panel discussion this evening. I have been at Abington as part of the labor and delivery team since I started my residency there in 1999. So I was lucky enough to be a resident with Dr. Perry, and in my training, learned a great deal from Dr. Picone. And as Dr. Megges and I finished residencies about the same time, we've been at Abington almost the same duration of time, with the exception of my couple of years of residency.
Great. And last but never least, Jen Johnson, can you go ahead and say hi?
Thank you so much, Dr. Perry. Hi, it's so wonderful to be here. I'm calling in from the midwife call room, and I delivered 2 babies today. So very excited to round out the day by joining you all this evening. I'm a certified nurse midwife, and I've been practicing as a nurse midwife for about 5.5 years. I'm originally from Northeast Ohio and have practiced in Tennessee, Massachusetts, and New York City in several practice types, and very excited to be here at Jefferson and be part of this really incredible collaborative practice where midwives and physicians can work together to raise the next generation of OBGYN providers. So thanks for having us.
All right. Well, then without further ado, I'm going to go ahead and get to your questions. We broke down the questions into 4 main categories: preparing for pregnancy, getting pregnant, being pregnant, and then labor and delivery. So we're going to start at the natural point about preparing for pregnancy. And our first question is going to go to you, Yulia. Can you comment about whether there are things that you should change in your diet when you are trying to conceive? And including any special tips for dads would be welcome as well.
Great. That's a really great question. And that's a question we actually touch a lot upon if people see us for preconception care. So it's a really big part of a healthy start to any pregnancy, is making sure that your diet and lifestyle is healthy prior to becoming pregnant. A good rule of thumb is that you would like to have a really good, healthy, varied diet and make sure that you're getting the best nutrition prior to becoming pregnant or while you're trying to conceive. A good varied diet includes lots of fruits and veggies, really healthy sources of fat. So a lot of unsaturated fats can be found in like avocados, nuts, olive oil. Those are all good sources. And you want to stay away from any kind of saturated or processed foods. I know we hear this all the time. And I know those cookies and baked goods are really delicious, and I'm definitely one to indulge, but that's one source of trans fats and the types of fats we want to stay away from as we're trying to better our diet. You also want to make sure we're getting a lot of good whole grains and good sources of carbs, like berries and different types of fruits are good sources of carbs on top of the whole grains. And then protein is really also important prior to becoming pregnant and during pregnancy. So lots of good sources of protein that are lean include beans and fish and lean meats like pork and chicken. Again, not cooking them in ways that increase our fat, so like avoiding fried varieties of those protein sources is good. And really generally, I recommend that folks follow the same precautions as if they were pregnant. So staying away from a lot of the exposures to mercury. So larger fish have mercury in them, like mackerel, swordfish. Staying away from like soft cheeses that could be made with molds or bacteria, like brie or blue cheese. And then staying away from undercooked or raw fish or meat. So we want to make sure our meat is really well cooked, and then staying away from raw fish like found in sushi. We typically tell pregnant folks to avoid. Those are kind of blanket recommendations that anyone can follow, including dads. So a lot of the foods and lifestyles and diet recommendations that we typically see that improve our fertility and make sure that we have a healthy weight and a good ovulation pattern have been tied to sperm quantity and quality. So following all of these same points that I just mentioned for dads is a really good idea. Another great thing to avoid for both parents would be alcohol and caffeine. Those two things have also been tied to lower fertility for both genders. So those are good things to avoid in general. Anything else you can think of, Dr. Perry?
No, that sounds great. That was such a great description. I love the fact that you really emphasize it's the partners together that have to work together for the healthy lifestyle. That's amazing.
Something you can do together.
Right.
Same plan.
So Jen Johnson, I think we'll move to you next about prenatal vitamins. So many questions about prenatal vitamins because it can be kind of confusing. Is there any specific prenatal vitamin that you recommend or that you think that people preparing for pregnancy should take?
Thank you, Dr. Perry. So I understand that there can be a really overwhelming amount of choice when it comes to many different things when you are thinking about conceiving and once you become pregnant. There's not one specific brand that I steer people toward when it comes to prenatal vitamins. There may be slight differences between different brands, but most prenatal vitamins will have the right makeup of micronutrients that you need to support a healthy fertility and healthy pregnancy. Just because something is more expensive doesn't necessarily mean that it's better for you. And you want to allocate resources appropriately as you're getting ready to build or grow your family. You do want to make sure that when you are thinking about conceiving and an early pregnancy, you're taking a prenatal vitamin with folic acid in it. And if you have any known micronutrient deficiencies like vitamin D, for example, that you're building that back up as you are trying to conceive and in the pregnancy as well. Anything else you'd like to add about prenatal vitamins?
No, I think that's great. And I think that point that the price tag does not necessarily equal the quality is such a very excellent point. Thank you for bringing that up. All right, Dr. Picone, on to you. What advice do you give someone who's thinking about stopping their birth control as they start their pregnancy journey? When should they stop it, and any other concerns they should have?
Fortunately, most of the reversible birth control that is available now is short acting. It acts during the time that you take it and really doesn't last for much longer after that. When patients ask or tell me when they are thinking of trying to conceive, I usually say to stop their either birth control pill, patch, ring, about a month or two before you're thinking of trying. Because for most women, the pill, the patch, the ring, all of that gets out of your system within a month or two of stopping it. The same with the intrauterine device. Once it's removed, within the cycle, its effect is usually gone. And so your fertility should be normal again after that. So you can start trying within a month or two of that. The only one that I find is more of an issue is the Depo-Provera, because since that is an intramuscular injection, that normally lasts 3 months in your system as birth control, but it does stay in the body for even up to 6 months later. So if you are trying to plan pregnancy with Depo-Provera, it might be a little harder to know when your fertility has fully returned. But for most of the other reversible methods, within a month or two, you're back to normal fertility. So plan it that way. So I usually recommend starting your prenatal vitamin when you stop whatever your birth control is, because for some women, they even conceive that very first cycle off of their pill, or the first cycle they stop their or remove the intrauterine device. And that's an indicator that everything did go back to normal. So it's not a problem that you conceive that quickly, but you should take your prenatal vitamin right when before you do conceive. So I usually recommend finishing or starting the prenatal vitamin during that last month of your birth control, or right around the time that you're stopping it.
Great. That's excellent, excellent advice. Thank you. All right, Dr. Meggs, next question to you. It's about exercise. So can you talk about preparing the body for conception, specifically about losing weight and exercise?
Sure. Just as our previous speakers have been talking about, it's so important to get your body healthy before you conceive, because you don't know exactly when you've conceived. And the most dramatic development of the embryo occurs in the first trimester. So you're basically going from the sperm and the egg coming together and creating this embryo all the way up to a small fetus, which is the formation of all the fetal organs, often before you would even know that you're pregnant. That's why the folic acid is so important. That's why it's important to, establish a pretty healthy, balanced diet. In the same light, it's really in your best interest to try to get to a good, healthy weight and get pretty fit, physically fit, before you conceive. That's not to say that if you happen to get pregnant and you are really out of shape and you aren't at the weight that you want, that there's no remedying the situation. But if you are planning your pregnancy, and I'm suspecting that most of the people on this webinar are, because you're before the bump, now is the time to really think about sort of optimizing your health in terms of diet and exercise. Because the weight can impact not only the developing embryo, but it can also impact your fertility, so your actual ability to get pregnant. Exercise doesn't really impact your ability to get pregnant, but weight plays a pretty vital role. We have some patients, but I would have to say it's a pretty small amount in our country at this given time that are underweight. And where underweight and too much exercise are making it difficult for them to conceive. Most of you are probably already Abington Jefferson chart patients and can go to my chart, and you can actually look at your body mass index, or BMI. We look at BMI, which is a calculation that combines both your weight and height to figure out whether you're in the target weight range that's ideal for you to be able to conceive, and also for your developing embryo and fetus. Underweight would be a body mass index of under 18.5, and that is very, very thin. If you are a patient that is very, very thin, maybe possibly has had an eating disorder or is an extreme athlete, exercise and your low body weight could impact your ability to conceive and could potentially impact your pregnancy. However, we struggle mostly with our patients being overweight and not exercising enough. Body mass index of between 18.5 and 24.9 is normal. And then between 25 and 29 is overweight, and 30 and above is considered obese. And right now we're finding that more and more of our patients are in the overweight and obese range. The pandemic has actually even made this problem worse. You will do your body a huge wonder of benefit by even losing a small amount of weight. I want to emphasize that we do not want you to sign up for a slim fast diet. We do not want you to go on any kind of extreme protein shake diet. What we really want our patients to do is to look at their day-to-day behaviors and try to cut out some of the pre-prepared foods, the fast foods, and the sugary drinks, the really easy things, and start to move more. When you see your provider for that preconception visit, they can tell you whether you're in the right range, tell you where you are, and what your targeted weight could ideally be within a few months or a few years, if that's how long you're looking at to plan your pregnancy. But the bottom line is that if you are struggling with weight, you don't want to beat yourself up about it. You don't want to like feel like the weight of the world is on your shoulders, but just change little things. If you're somebody who has typically been going to Starbucks and getting a big latte with lots of sugar in it, switch to just a plain coffee with a little artificial sweetener, or maybe no sweetener and just some milk or cream. If you like to drink soda, try to switch to seltzer. If you're a juice drinker, maybe drink mainly water with just a tiny bit of juice to sweeten it just a little bit. So maybe like a 10% juice, 90% water. But find ways that you can reduce the sugars in your diet, especially the sugars and the fats. And it's easy stuff like the drinks. And then in terms of exercise, if you are pretty sedentary, start slow. You don't want to get injured, but the more fit you can get before you try to get pregnant, the better off you're going to be at handling your pregnancy, because pregnancy is a state that is hard on your body. It can be tough on your back, and labor can be physically challenging. So you really want to get fit and strong before you get pregnant. Being overweight does increase the risk of pregnancy complications beyond fertility. So with fertility, even losing up to 10% of your body weight, or even just 10 pounds, can significantly increase your ability to conceive. And if you are significantly overweight during your pregnancy, you can potentially increase your risk of problems with high blood pressure diseases of pregnancy, diabetes of pregnancy, preterm birth, babies that are big enough that you could potentially have difficulty pushing them out and need help with delivering those babies, either through what we call operative deliveries, like a vacuum delivery where we help to pull the baby out, or C-section. Certainly our heavier women are having a higher rate of C-section. And there's also an increased risk of stillbirth for very, very heavy women. So trying to get your weight down, even if it's a small amount, is going to be extremely helpful. Let me see if there's anything I missed. Oh, in terms of daily exercise, what is recommended is that people aim to try to get about 150 minutes of exercise a week, and that's moderate activity. If you think about that, that's about 30 minutes of exercise 5 days a week. And it's been proven to be more beneficial to your overall health than weight loss. So if you can actually get your heart muscles pumping and you can get your body moving, you're going to improve your health for the pregnancy probably more than losing a significant amount of weight. So get out there and do start doing that 30 minutes of exercise 5 days a week if you can. Start with a brisk walk, but if you can start to do some more like strengthening exercises, that's wonderful. And if you can get your heart rate up a little bit higher than a walk, like up into the 120s, 130s, that would be fabulous. That's it.
Wow, thank you for all that very practical information, Dr. Megges. So on to you, Dr. Ruiz, who's been waiting so patiently over there. Could you tell us, should you wait a certain amount of time to conceive after COVID, and for that matter, after the COVID vaccine, if you could include that in your answer?
All right. Well, we don't have a lot in terms of research on the subject, although this is a very timely question, given that we are emerging from the pandemic. As you probably have already picked up on the theme here, I always say that a healthy mom is the best starting place for a healthy pregnancy. So I would recommend for women who have, been affected by, the COVID virus to wait until they've recovered and back to their usual health of state. And that's going to vary from women to women. In terms of the vaccine, again, there's not a lot of research, but the research that is coming out is suggesting that there's not necessarily a waiting period necessary.
Okay, excellent.
So, as this is, an emerging topic, I would expect, more formal recommendations to start being discussed.
Excellent. All right, and so Yulia, I'm going to go on to you, and we're going to do a twofer because we have one of the questions that came in, which is how to choose a provider that I wanted to ask you. But someone in the Q&A just asked, what role does a midwife play? So maybe you can merge those questions together about choosing a provider and the role that you play as a nurse midwife.
Yeah, that would be great to combine. So I'll start with how to choose a provider that's right for you and your pregnancy. We can kind of divide it into two little categories. One is your wishes and hopes for your pregnancy and delivery, and then whether or not your pregnancy might be on the lower risk scale or more high risk. If you have a trusted, established gynecologic provider who may or may not be an obstetrician or a midwife, it may be helpful to ask them. They know your health history really well and can maybe help gauge and tell you if perhaps if you got pregnant in the next year, you would be considered more of like a higher risk pregnancy or a lower risk pregnancy. I know sometimes both of those terms can be really broad, and not everybody knows what conditions fall under each one. So you might be able to get good education from a provider that you already have. And then the other part to it is kind of your wishes and hopes for pregnancy. Were you looking more for example, a more pregnancy where you spend a lot of time with your provider, hoping for an unmedicated or quote unquote natural birth, or perhaps you're somebody who's had cesareans before and you know that your next baby will be delivered by C-section from prior recommendations. So really kind of mapping out what kind of experience you want and whether or not you need higher level of care is a good place to start. Midwives, certified nurse midwives, which Jen and I are both certified nurse midwives, are equally, trained, high level of training, and obstetricians as well. And we provide just different levels of care. So midwives care for women that are typically undergoing a lower risk pregnancy. They're typically healthy and not entering pregnancy with any chronic conditions, like, for example, diabetes managed with medications, or very high blood pressure, or being on blood pressure medications. Those are two common examples. And a lot of people also choose midwives because they want a more high touch, low tech experience, meaning we provide a lot of hands-on support through labor and spend a lot of time with our families explaining things. Obstetricians are just as equally skilled in those things as well, but many times they have a patient load or are having patients with more complications and are taking care of women across the spectrum of kind of normal and high risk. So those are the places I would start. And if you have questions about, specific questions about whether or not a midwife or an obstetrician is right for you, asking your provider you already have is a good starting point. A good thing about our system that we all work in and all the offices we work in is that you have access typically to a midwife in your office, to nurse practitioners, midwives, and obstetricians. So the beauty of choosing Jefferson Health is that you could meet and discuss your care with different types of providers and get to know people and establish a relationship and see what may be a better fit. And also get education from us of whether or not you might be an appropriate candidate to see more physicians for your care or have a midwife for your delivery.
Great. I love how your answer really highlighted the collaboration at Abington between all the different providers, which is one of the reasons I love it so. Also, that segues also perfectly into another question in the preparing for pregnancy grouping about, and it came from a couple women who had medical conditions like diabetes or epilepsy or a heart condition. And they wanted information about how pregnancy might affect their disease or how disease might affect their pregnancy. So there's kind of a couple different ways if you have a medical condition that you should go about it. go about preparing for pregnancy. The first, as we've already alluded to, is optimize that medical condition with your provider who cares for it, whether it's your primary doctor or a neurologist, an endocrinologist, whatever. You should also then go for a preconceptual counseling visit. They'll start Jen's Prenatal Vitamins. They'll give you the great information that Yulia just gave you about diet and what Dr. Megges told you about exercise. But they'll also determine whether or not you should see a MFM doctor, or it's also called a high-risk doctor or a perinatologist, who might be able to give you very specific information about how your condition affects pregnancy, how pregnancy affects your condition, and will help to kind of paint a map for you to follow to have the best outcome of a healthy mom and a healthy baby. Likewise, for people on medications, pregnancy might affect your dose of medication. You might need a medication change for something that's safer. Those are all conversations that either your obstetrician gynecologist can have with you, or your provider can have with you, or maybe refer you to a perinatologist for those questions. Definitely to do before pregnant if you're able to. Okay, we're going to switch veins, and now we're going to talk about getting pregnant, and we're going to start with Dr. Picone. So Dr. Picone, this is the hot topic of the webinar, and it's about ovulating. Everyone wants to know, when am I ovulating? How can I tell if I'm ovulating? How should I track my ovulations? Please inform us.
So in women who are trying to conceive and are having normal monthly cycles, we always count the first day of your period as day 1 of your cycle. Most women will ovulate around day 12 to 14 on average. And then if you don't get pregnant, your period will come about 2 weeks later. So that's why most cycles are 28 to 32 days in length. So that's average. So one way to try to see whether you're ovulating, if your cycles are regular and predictable, most times you are ovulating regularly. That's why your cycles are so regular. But something that you can do to try to better predict it is an ovulation predictor kit, something like Clear Plan or Clear Blue Easy, which is like a pregnancy test where you test your urine in the morning, but instead of testing for the pregnancy hormone, it actually tests for the hormone that causes ovulation to occur. So it predicts when it turns positive that you're going to ovulate about 24 hours later. So it's recommended to have intercourse every day to every other day during that middle time of the cycle, because it does take sperm about 24 hours to reach full maturity. So you shouldn't have intercourse 2 or 3 times a day to try to get pregnant, because that actually will decrease your chances. Once a day is really optimal. Don't use any kind of lubrication. Try to stay lying down for another 20 to 30 minutes after intercourse to give time for the sperm to get in. But most women will ovulate around that day 12 or so, 12, 13. So you should use the ovulation predictor kit, usually starting around day 10 in the morning, and then it will trigger when you're going to ovulate the following day. So it predicts when your most fertile time will be. In couples who are actively trying to get pregnant, about 60% are pregnant after 6 months, about 85% are pregnant after a year. So it's not unusual that it doesn't happen within the first month or 2, so don't be discouraged. But for most women, it will happen within the first 6 months and certainly within a year. So if your periods aren't regular, if they're every 5 weeks, 6 weeks, they vary, then you might need to see your doctor sooner, because if you're not ovulating, obviously it decreases your chance for pregnancy then. So we don't want you to try for a year if your periods aren't regular, because there are a lot of medical conditions like thyroid disease, polycystic ovaries, different things that can be treated to then optimize your chances for fertility. There are a lot of apps available where you can track your cycles as well. Again, that's also predictive of if your cycles are regular, you can then predict where your ovulation probably is. But if you want to kind of test a few months to see roughly when am I ovulating, then the ovulation predictor kits are probably the most helpful things, because then you can really be sure you are ovulating and roughly when it's happening. You wouldn't have to do it every month if your cycles are regular, but at least it can confirm that you are ovulating on the months that you test.
Excellent, thank you. And that segues perfectly into Dr. Meg's question, which is about PCOS. A lot of questions about PCOS, which stands for polycystic ovarian syndrome, and about ovulating and what people should do if they have been diagnosed with it or suspect that they have it and they're thinking about trying to get pregnant.
PCOS is a really common topic of confusion for us OBGYNs and midwives. I feel like there's like a big rumor community about like whether I have PCOS, what is PCOS? And it's partly because PCOS doesn't have like a simple test to prove that it exists, which makes it very confusing. And I've even had the experience where one of my colleagues tells a patient that she has PCOS, and then another colleague says, no, I don't think you have PCOS. So PCOS isn't a black and white condition. It's called a syndrome. And it has a few different defining characteristics, but there's not even one clear-cut definition. To keep it simple for you all, it is basically a problem with ovulation or with the quality of the eggs that you produce with ovulation. And it is diagnosed often either when you are in your late teenage years, when your periods are supposed to start getting really regular and they don't, if in fact they start to fade way out, or it's diagnosed sometimes when a woman is actually starting to try to get pregnant and it's not happening, even though she has a period every month. So those would be sort of the two different definitions: a problem with ovulation, which would present with like not getting periods regularly, or getting periods regularly but not being able to conceive because of the quality of the egg. And that's not the only reason why you can't conceive when you get regular periods, but it's one of the reasons. Typical things that might tip a doctor or yourself off that you might have PCOS would be acne that's worse than what most teenagers experience. Typically, the acne for people with PCOS is more prominent on their chin, their back, and their chest, and can persist into their 20s, past their teenage years. Increased hair growth on the chin, between their lip and their nose, and on their lower belly. That's more than what other family members have, because hair distribution can be very specific to different, areas of the world and culture and ethnicities. And then also sometimes people who have PCOS have more difficulty controlling their weight. I would say that if you suspect that you have PCOS, you should definitely go bring it up with your OBGYN, and you and they can start to solve that mystery or try to get to the bottom of that question. We specialize in making this diagnosis, and it is sometimes not until you're actually trying to conceive, even if you menstruate regularly and you don't have any of the other symptoms that I'm describing, that you would actually find out that you have PCOS. So I'd say if you're under the age of 30 and you've been trying for 6 months to a year, you might want to go to your obstetrician, especially if your periods are not coming regularly, and ask them about this possibility. The good thing about PCOS is that there are things that we can do to help control it and to optimize fertility. One is, and I know this is hard for some people, but when you are in a relationship or a place in life where you know that you want a child, the earlier or the younger that you try to get pregnant if you have PCOS, the higher your odds are of being able to conceive naturally without assistance. And then the other thing, and I know I was the last one to be talking about weight, but if you do lose just a little bit of weight and you do have PCOS, you can pretty significantly increase your odds of getting pregnant. I think if you're not menstruating regularly, and Dr. Picone was talking about the ovulation kits, and if you use one of these apps and you're not banging out those periods in any kind of a pattern, it becomes so frustrating to try to get pregnant without the assistance of a fertility specialist, because you just have no idea when to have sex. And that can become really, really, really exhausting and upsetting as a couple. So I would strongly recommend that if you are not getting pregnant, and if you're over the age of 30, you have PCOS and you're not getting pregnant or you're not ovulating regularly, go seek the help of a fertility specialist earlier rather than later. The good news is that we have some really simple medicines that you just take by mouth that aren't particularly expensive that can really, really help people with PCOS get pregnant. So you're not necessarily looking at doing IVF in order to get pregnant. If we can help you when you're young or when, early enough in the game, there is a very decent chance that you can get pregnant on a medicine called letrozole, Letrozole. It helps about 80% of PCOS patients ovulate, and about 40% of those patients will conceive pretty soon after they start that medication. So that's about it on PCOS.
Thank you so much. Again, very detailed. We appreciate that. I think I'm going to change tack a little bit and skip over to being pregnant so that we can get some of these questions answered. And I think between Dr. Picone's and Dr. Meg's answer, we got a lot of the other questions answered about infertility evaluations. So Yulia, I'm going to go back to you for being pregnant. So after someone gets a positive pregnancy test, what should they do? And can you kind of describe what the first few visits might be like?
Sure. So after you get a positive pregnancy test, the recommendation is if you're seeking to establish prenatal care, you want to contact the office in which you'll be beginning your prenatal care and make an appointment there for your first prenatal visit. It could be in the office you already go to if there are providers that provide birth and delivery care, or you may need to do a little bit of research and find a place to go, whether you're seeking a collaborative practice with both midwives or physicians or one or the other. The first visit is typically the longest. I typically tell people to just get comfy because we'll spend a little bit of time together. At this visit, we collect a history about your health and information about when you might have become pregnant. So we ask a lot about your cycle and how regular it is. We perform a exam that's head to toe just to get a baseline exam and make sure that you're starting your pregnancy healthy, or if there's anything that we suspect that needs more follow-up, we'll let you know. And then we do quite a bit of education, a lot of which you already heard today. So we talk about your diet, what to avoid. If you're experiencing normal early pregnancy discomfort, we address that. So nausea, vomiting, headaches, and then we talk about warning signs and when to call your office for things like bleeding or any kind of suspicious pain. And we go over quite a bit of that during the visit. And then many times you have to expect to get quite a bit of paperwork and educational material. So you might get some homework and reading to take with you to read about normal pregnancy and warning signs, which can be overwhelming to go home with that much to read, but I do encourage you to take a look at it. You can gather some pretty good questions to ask us during your appointments from that information. And then going forward in normal pregnancies without any complications in the beginning or need to see you more often, we'll continue to see you every 4 weeks. And during those appointments, we check in to see how you're doing. We check on your baby, take a listen to their heartbeat, and go over any testing or any results that we may have ordered at the prior visits.
Great. It's again, another perfect segue, because we're going to go over to Dr. Ruiz about testing and results. So Dr. Ruiz, can you talk about the advice you give patients about choosing genetic testing during pregnancy?
Well, I'll give an overview because I think all the various testing options, their limitations, expectations, could take a whole webinar in itself. So I'll just give a very quick overview. The common genetic testing options include procedures such as an amniocentesis, chorionic villus sampling, which CVS for short, or blood tests, ultrasound, and testing options that include a combination of ultrasonography and blood testing. You know, testing is offered across the board for all patients. However, which type of testing is actually recommended is going to vary based on risk factors and the patient's preference, and such as what their expectations are, family history, age. But testing is offered. Finding or discussing what option is best for a couple is one of the hallmarks of a visit with a provider.
Okay, great. Thank you so much. That's excellent. And so Dr. Picone, we're going to go back to you. And it's about travel and pregnancy. People want to know if they're pregnant, is it safe to travel either by car or by airplane, domestic or international?
For most women who are having a normal, uncomplicated pregnancy, travel is fine during pregnancy. We usually make a recommendation not to fly after 34 weeks, just because we don't want to increase your risk for preterm labor, obviously while you're in an airplane flying. But for most women, if you're not having bleeding, preterm labor, you can usually fly safely up until about 34 weeks. The second trimester is probably the best time to fly because your risks for miscarriage are less. The risk, again, for the preterm labor is less. So the second trimester is when most women feel the best. So usually that's the best time for flying. If you are going to fly, especially if it's for a significant distance, like overseas, we recommend getting up and walking around, flexing your feet while you're sitting in the airplane, wearing support hose, because immobility does increase your risk for swelling in the legs and possible blood clots in the legs. So we want your feet to be active, moving your legs around, and to try to decrease that risk. The same would go for car travel. If you're going to be on a long car trip, again, flex your feet, get up and stop the car, walk around just to keep your circulation going to decrease any swelling. Driving is safe in pregnancy up until the end. Just make sure you're always wearing your seatbelt. Airbags are safe to have activated while you're driving. They are very protective, so don't be concerned about that. And for driving, we usually say once, again, that you get closer to the end of the pregnancy, not to drive probably 2 hours or more away, because if you do go into labor, we want you to be able to get back safely in time. So just be careful of any kind of trips that you'll be making once you get full term.
Excellent. Yeah, the state policemen don't like that. All right, since you have the active live mic, there was a question in the Q&A about whether it's an old wives' tale that you should leave your feet up in the air after you have sex to improve the chances of conceiving. Since that was your question, would you comment on that?
Usually I don't recommend leaving your feet up in the air. Just lying supine is sufficient because for most women, the uterus and cervix are at a certain angle. The vagina is at an angle. So the sperm will stay kind of pooled at the back, right where the cervix is. So you don't have to lift your legs. Just don't actively get up and start walking around because then it's more likely that the sperm will come out. So you should at least lie down for 20 minutes.
Great. And so Yulia, back up to you. Can you talk about what medications are safe for cold and flu in pregnancy? And I guess while you're at it, since it is high time for allergy season, mention what you recommend for allergies. That'd be great.
Yes, good point. I feel like all of us are struggling, myself included. So good and safe cold and flu medications that can be found over the counter are any of the Tylenol cold and flu series are safe. None of those include an NSAID. So NSAID is a drug class that includes things like Motrin, ibuprofen, aspirin. You want to avoid that during pregnancy as much as possible, unless you're told by your provider to take those during pregnancy. And so the Tylenol in general is a safe pain reliever in pregnancy, whether that's for a headache or a cold or flu. And the Tylenol series typically has things like a cough suppressant in it and a decongestant. So it's a nice way to combat multiple symptoms with one medication. You can also do things like Mucinex and like Vicks Vapor Rub. Those are safe things. Some supportive measures to try to are saline nasal spray. So that's a really low risk intervention that doesn't have any kind of medication. It's just saline, or a neti pot. Those are all good things to try. If you think you may have the flu, definitely, obviously, flu symptoms can be kind of confusing now that we're in the pandemic, but if you're having upper respiratory symptoms that you suspect you may have the flu, please do contact your provider or seek a way to get tested, because you can get Tamiflu, which is the flu medication that if started at the beginning of your symptoms, can shorten the duration and severity of flu, and you can take Tamiflu in pregnancy. So please seek care when you get symptoms, because you are eligible to take that medication. And then if you're an allergy struggler, most allergy medications over the counter, like Claritin, Zyrtec, Allegra, are safe to take in pregnancy. So feel free to purchase that over the counter along with Benadryl as well. And hopefully you'll get some relief from those symptoms.
Okay, there's so much to learn and there's so much to share, but we are running short on time. So just time for probably a couple more questions. Dr. Ruiz, I'm going to ask you to comment about whether you could tell in advance of your labor and delivery experience whether you need a C-section. Could you particularly mention about whether, like, if your mom had a C-section and your grandmother had a C-section, does it mean that you're going to need a C-section?
Well, what sounds like a simple question has a very complicated answer.
We don't have that much time, Dr. Ruiz.
So when trying to answer this question, I'd like to start off with one basic statistic. About 1 in 3 to 1 in 4 women will deliver by C-section with us at Jefferson Abington. The objective always being to deliver the baby in the safest way possible for mom and the baby. So for the most part, a vaginal delivery is considered to be safest for mom and baby. But some of the common reasons to deliver by C-section depends on how the baby's positioned, how the baby's tolerating labor, and how mom's labor is progressing. So in particular, to that question about if family members have delivered by C-section, does that mean that you will deliver by C-section? I think I'll pull from my own experience. I was lucky enough to care for 3 sisters who were all delivered by C-section, but and only 2 out of the 3 delivered by C-section, and 1 delivered both of her children vaginally. So although there are always stories clustered in families, it's never 100%.
Excellent. Thank you so much. That's excellent. I'm going to go to some of the live questions. Jen Johnson, prenatal vitamin lady. So can you talk about probiotics? Are those okay? Do you recommend them in pregnancy?
Great question. I love probiotics, and they are safe in pregnancy, as well as foods that contain good bacteria for good gut and vaginal health. So things like Greek yogurt and kimchi. Probiotics that have Lactobacillus rhamnosus specifically are very good for vaginal health. And so I certainly recommend that pregnant people take a probiotic with that specifically in it. There are a lot of brands out there. And as you know, I'm not a brand manager for anything, but especially having good gut and vaginal health can decrease your chance of group beta strep or GBS, which is not an infection, but an overgrowth of a common bacteria in the vaginal canal that we test everyone for at the end of pregnancy. And so that's something I certainly recommend to try to decrease your chance of that.
Excellent. Thank you so much for sharing that. And I'm glad you're not a brand manager, so you can just speak freely about whatever you want. Speaking of brands, Dr. Megges, someone asked specifically about CrossFit, and since you seem to be the exercise lady, can you talk about CrossFit and whether you can continue with CrossFit during and if you don't know much about CrossFit, just maybe some exercise guidelines, things that you should definitely avoid in terms of exercise, heart rate, weights, etc.
Sure. Yeah, I have a basic understanding of CrossFit, and so there are CrossFit should be fine if you're healthy and you're fit. If you are not, I would certainly start slowly. There is no longer a heart rate restriction, despite the fact that you will probably read it in a lot of literature and books about pregnancy, because it used to be that we used to have a cutoff of a heart rate of 140. The guidelines have changed, and we now are aware that when women are fit and exercise, they should be able to sustain higher heart rates without any danger to the baby. What's most important really is to listen to your body and to take breaks when you're really, really feeling out of breath and fatigued. So instead of using the heart rate guidelines now, we've turned to the can you carry on a basic conversation or even just say a few words back and forth to somebody else? If you're able to do that, then you're probably you're definitely oxygenating your baby well enough. Your baby is not going to suffer from your heart rate being high. The other thing is that you want to stay well hydrated. When you're pregnant, you have increased fluid requirements. So you want to drink, you don't have to drink the whole time you're exercising, but you want to drink well before you exercise. And then the other part of CrossFit obviously is a lot of strength training, including lifting weights, lying on your back. I don't know if sit-ups and other exercises where you're actually using your core are part of CrossFit, but it is healthy to strengthen your core throughout your pregnancy. It is healthy to lift weights or do strength training throughout your pregnancy. The one thing you do want to keep in mind is that you really want to protect your lower back when you're pregnant. There are a few reasons why your lower back is more vulnerable to injury. One is that you have postural changes because of the weight of that growing uterus. The second is that you have some hormones that are making all your ligaments a little bit stretchier. And then the third is that your belly muscles are all stretched out, so they can't support your core as much. So the more you can strengthen your core, including your abdominal muscles, but also like your thighs, your buttocks, and your back, the less likely you're going to have a back injury. So keep up the exercise, keep the strength training going, keep getting out there and getting your heart rate up. The fitter you can stay, the better you're going to endure the tough third trimester of pregnancy and then that final marathon of the delivery.
Wow, marathon. Great. Thank you so much. So back to you, Yulia, since you talked about at the very, very beginning, you talked about diet in pregnancy and in conceiving, when thinking about conceiving. You did mention protein sources, beans, and I think lentils, but do you have any other recommendations for someone who's trying to follow a vegan diet?
It's a great question. Good plant-based sources of protein do include things like beans, which can be like, canned beans that we buy, or soybeans. A good source of protein for somebody following a vegan or even a vegetarian diet can be tofu. That's a really good source of protein that you can purchase. Trying to think of other ones. Maybe my panelists can help me. Some plant-based sources.
Quinoa? Did you say quinoa?
Quinoa, yes, that's a great one. Yes.
Good one. All right, so it's possible to do. You just have to
Jen,
shop widely.
what did you say, Jen?
Oh, sorry. I said rice and beans together are a good complete protein. And I agree with everything else that you shared about nuts, nut butters, tofu, legumes, etc.
Great, thank you.
There's been a few questions about getting pregnant after a loss, so I'll just address that. So as I think Dr. Megges alluded to earlier, pregnancy loss is a relatively common experience. About 20% of women have, or 20% of pregnancies end in loss. The good news is that having one miscarriage puts you at no increased risk for a subsequent miscarriage. And when patients ask me, like, when can I get pregnant again? I always explain that there's two types of healing. There's physical healing and then emotional healing. In terms of physical healing, you could expect to get a period in about 4 to 8 weeks after a miscarriage, depending on whether it was a spontaneous miscarriage or you had a procedure or it was handled medically. Usually you'll get your first period 4 to 8 weeks. And after your first normal period, it's fine to go ahead and start trying again. You are physically ready. Emotionally ready is different depending on the patient and really depending on the couple when they're ready to try again. And that's highly variable. And of course, we always have perinatal support for people who have suffered a loss and feel like they need some help getting those emotions in check. And Dr. Ruiz, I'll go to you next for the next question. And it's just like ovulation, it's a big question, and it's about hair dye. Can we do it when we are pregnant?
Absolutely.
Excellent. Fabulous. Any problems?
No questions, no equivocation.
Okay, fabulous.
Whatever color you want.
Wow, I didn't know you were going to be that fast. I'll have to find another question. Wonderful. So I guess my next question would be for, I guess I'll punt it to both Yulia and Jen about supporting someone through an unmedicated birth. Someone had a question about doulas versus midwives, and gee, it really doesn't sound like I need a doula if I have the more, I think you called it high touch delivery, Yulia. So do either one of you want to comment on that?
Sure. Yeah, I think a really common question that the average person and also many providers who have never worked with midwives before is, what is the difference between a midwife and a doula? A midwife is a medically trained provider. Yulia and I are both certified nurse midwives. So we have training as nurses, sit for nursing boards, and then go on to receive a master's level education and sit for midwifery boards, and then credential regularly with continuing education. It's very similar to a nurse practitioner. We do provide high touch, low tech, so we can, just like our physician colleagues, anyone can provide that hands-on support, like additional education, massage, showing someone where to press here or there in your labor, and I'll get to that. But doulas are not medical providers, so they don't order testing or conduct medical assessments. They're really there for physical, emotional, and mental support, but they're not there to deliver your baby or to, tell you what to do in a certain situation. They're there to really be a companion to help the person in labor or help your support people help you best. And as Yulia alluded to earlier, all of us are able to do those things. And when you're at a high volume place, we often have competing responsibilities with many people. And so the benefit of having a doula with you in labor, whether you're being cared for by a midwife or a physician, is that you are their only client and they're there to be with you every step of the way. Your midwife, your nurse, your physician, depending on the length of your labor, may change out over time and is not often there in the room with you throughout the entire time. So that's kind of one piece of it. And then in terms of labor support and unmedicated labor, I like to tell people that feeling physically and emotionally safe is a really great way to relax your entire body and allow labor to progress the way that we want it to. So staying home as long as you can in early labor, being able to be in the shower, in the tub, utilize hydrotherapy, play music, sleep in your own bed, that kind of thing. There are certain times that we want you to come into the hospital, and your provider can tell you that. So I won't get into the weeds with that right now, but once you're here, you can still bring those comforts of home. So you can bring your own clothes, your own pillow, make a playlist. I often tell people when it's time to push, like, do you want music on? I've delivered babies to Beyonce and Taylor Swift music and, whatever. So you're welcome to do that. Being able to move freely in labor and walk around and do all of that is really great. And there are some other methods of physiologic support we can offer in labor as well. So anything else you want to add, Yulia?
No, that was really great. The only other thing I'll add is that a doula can also be a helpful person for your partner. I think partners a lot of times don't know what to do or don't know how to support their partner in labor. So utilizing your doula to show your partner how to support you in labor is really helpful. Your partner knows you the best and has known you the longest out of everybody that's going to be in that room. So them providing you hands-on support and talking to you during labor will probably provide the most comfort. So utilizing your doula to show you techniques is really helpful.
Okay, that's awesome. Well, again, I wish we had time for more questions because this is so much fun. And I hope our audience can see just how passionate we are about everything that we're speaking about tonight. But we do have to start closing up. But before we do, if each of our panelists could just give a little blurb about what their goals are for our audience tonight, like what they hope they take away from this webinar. And we'll start with you, Dr. Picone, please.
I hope that the audience understands, like you said, that we are passionate about what we do, and that they can come to us with any questions, concerns, and really try to have the best experience with obstetrics and their delivery and postpartum time. That's really our goal, is to have you get the best experience that you can. And so we really want it to be a collaboration with what you want and how we can help you to achieve that.
Beautifully put. Thank you. And how about you, Yulia?
I would say that we provide a lot of general advice and have given out a lot of information. And the first step to a healthy, just your own health and a healthy pregnancy is getting as much information as possible. But the key is to know that a lot of these things are individual. So to touch base with your provider and make sure that you're getting the care that's right for you is also really important. So gathering all this information and asking good questions at either your appointments or future webinars, it is something that I would recommend doing.
Excellent. Thank you. And Dr. Megges, on to you.
I'd like to remind everybody that this is a really exciting time in life, and sometimes we start like measuring and quantifying and paying attention to all these tiny little details when if you think about all the women all over the world getting pregnant without the quote unquote high-tech information, if you just relax and celebrate this time of building a family, for the most part, things will just go okay. They'll go well. And you do have us. You can turn to us, but enjoy the process.
Thank you. Very optimistic message. And how about you, Dr. Ruiz?
Well, we mentioned it just briefly in terms of a preconception visit, but I encourage it. I think it's something every couple should consider. I know as providers, it's one of the most rewarding visits and encounters that we have, is to be able to help a couple on their road to parenthood and make recommendations that are both general and individual by knowing their histories, their family histories, their personal objectives. Do they want one child? Do they want 5 children? And the family histories as well. So I think that may be a very underutilized option. And again, we as providers welcome it because it is one of the most rewarding kind of visits that we can have in our day.
Thank you. It is fun to start the journey with them. And we'll, again, last but not least, Jennifer Johnson.
Thank you so much, first of all, Dr. Perry, for leading this whole wonderful group in tonight's panel. And thanks to everyone who is here with us tonight in person or perhaps watching from home at the recording. The main message I always like to get across is that you and your care provider are really a team in partnership, each bringing your own expertise to the table and making decisions together with you at the center. You really are the expert in your own experience, your own goals, your own body and sensations. And I hope that everyone finds a provider who they can trust and that you can work together to optimize your health, your pregnancy, and everything moving forward. So thank you so much.
Thank you. And I don't know how I can top any of that, so I'm not even going to try. So I would like to say thank you, Yulia and Jen and Dr. Megges, Picone and Dr. Ruiz. And really, thank you to all of our audience members for submitting the questions and for spending all this time with us this evening. It is really so meaningful for us as well. So at the end, you are going to be sent out a survey. We do appreciate if you complete that survey. You know, was this helpful? Did you like the time? Is there more different specialties you'd like to hear from? Your feedback helps us provide you with the best possible wellness webinar experience. And if there's anything that we can do for you for here at Jefferson or at Abington Hospital, please do not hesitate to reach out. And if you're interested in learning more about more wellness webinars, you can find that information at jeffersonhealth.org. We are also on YouTube for our wellness webinars can be found there as well. So I think that is it. Oh, it's youtube.com/C/Jefferson Hospital. So once again, thank you so much for joining with us. Stay safe out there, and we look forward to seeing you. Go well, everyone. Thank you so much.